Hello and welcome to Tala Talks NICU, where we take complicated medical concepts and make them super easy for you to understand and to retain forever. Today we are going over the last part of the series on TPN. So if you haven't watched the first two videos, then go back and watch them now. Basically, in the second video, we went over how to write for the rate of TPN, as well as how to write for glucose, fats, and proteins. Today, we're going to go over everything else that's in TPN. So just a really quick reminder to like this video and to subscribe if you're interested in neonatal stuff, and to carry on sending us comments. We love hearing from you. We love hearing from where you are in the world as well. So today we're going to go over the minerals that we put in TPN, the trace elements, the multivitamins, and then all the other kind of random stuff that we also put into TPN that actually isn't random at all. So let's start with the minerals, or more specifically, we'll start with the positive minerals, or the cations, the ones with a positive charge after them. So we're going to start with sodium. Obviously, sodium is a critical part of our body, and a normal sodium level in blood is between about 135 to 145 milliequivalents per liter. A baby, a preterm baby or a term baby, can need anywhere between 0 to 8 milliequivalents per kilo per day of sodium. Normally, once they kind of settle out, if they're not on medications, if they're not super sick, if nothing else crazy is going on, then basically babies end up needing about 2 to 3 milliequivalents per kilo per day. I want to talk really briefly about the concentration of sodium and the milliequivalents and the normal saline and everything, because it seems to really confuse people. The concentration of normal saline is 0.9%, which means that there are 0.9 grams of salt, which, as you all know, is sodium chloride, in 100 mLs of water, or 9 grams of sodium chloride in a liter of water. Now, the molecular weight of sodium chloride is 58.4 grams. So if you remember from your periodic table, the molecular weight of sodium is 23 and the molecular weight of chloride is 35.4. So altogether, 58.4 grams. Hear me out, I promise you that this is relevant. So 1 mole of sodium chloride is 58.4 grams. Now, as we already said, normal saline, or 0.9% saline, basically has 9 grams of sodium chloride per liter. And since there are 58.4 grams of sodium chloride per mole, then in a liter of normal saline, you would have 9 divided by 58.4, or 0.154 moles of sodium chloride. Another way of saying 0.154 moles per liter is 154 millimoles per liter. Now, since sodium chloride dissolves into 2 different ions, sodium with a +1 charge and chloride minus charge, then you'll end up with 154 milliequivalents of sodium and 154 milliequivalents of chloride. This equals a total osmolarity of 154 plus 154, which is 308 milliequivalents. The osmolarity of blood is about 285 milliequivalents per liter. However, sodium chloride doesn't have a perfect dissociation. So really, 0.9% saline is actually a very similar concentration as blood. And that is why we call 0.9% or normal saline, because it is isotonic to blood. Now, you all know that if you give a very hypotonic solution, so for example, you just inject water directly into the blood vessels, then what's going to happen? The red blood cells have a higher concentration of solutes and everything than the water that's been injected. So what is it going to do? Through the process of osmosis, that water is going to go into the red blood cells and cause the red blood cells to burst. The other thing will happen if you give a very hypertonic solution. So if you give a solution with lots and lots of solute in it, then the fluid within the red blood cells is going to leave the red blood cells and go into the blood vessels. causing those red blood cells to shrink away and die. So what you're really trying to do is get the absolutely perfect concentration to put into those blood vessels so the fluid can stay within blood vessels for as long as possible. And that is why we use isotonic solutions, or in this case, normal saline. A few more things pertaining to sodium and specifically how to write it in the TPN. So as we discussed over and over again, babies are born with a lot of extracellular fluid. So they're born with too much fluid. And in the first few days of life, they're basically getting rid of this as they diurese it out and they have more insensible fluid losses. Because of that, whatever sodium that they're born with, generally that number will creep up in blood over the first few days of life. In a term baby, that might go up by a few points. In a preemie baby, that might shoot up really high. So generally in the first few days of life, we do not add sodium to the TPN. We wait for babies to kind of hit their nadir of their weight. And then if the sodium is okay at that point, then we can start adding it. In fact, very often in the first few days of life, we have to add a lot of excess fluid, maybe up to 180 or 200 mLs per kilo per day, just because the sodium got so high. The second thing that you need to remember is that in those first few days of life, when we're just really concerned about that sodium shooting up, babies also might be getting sodium from a lot of sources that you're not necessarily thinking about. For example, they could be getting sodium in their UAC fluids, in the second port of their UVC. They could be getting it with medications. Even the flushes that we give into the lines probably contain sodium. So if your sodium does continue climbing, then in addition to giving free water, make sure that you're looking into all the other different places where a baby might be getting sodium. And I'm going to give you a very good example of this. Let's assume you have a 500-gram infant getting 1 ml an hour of half normal saline through the UAC. 1 ml an hour is a total of 24 mLs a day. If there's 154 milliequivalent sodium in 1 liter or 1,000 mLs, then to calculate how many milliequivalents we have in 24 mLs, it's 1,000 divided by 24 equals 41.67. So that means that we have 154 divided by 41.67 equals 3.69 milliequivalents of sodium in 24 mLs of half normal saline. If the infant is 500 grams, then that's a total of 3.69 milliequivalents times 2, because to make it up to a kilo, then that's 7.38 milliequivalents per kilo per day just from the UAC fluids. So you can see how that adds up really, really easily. Generally, like I said, when you reach status quo and the baby's stable and you're kind of on full TPN, then the baby probably needs about 2 to 3 milliequivalents per kilo per day of sodium chloride. Obviously, there are loads of situations where baby may need less or a lot more than this. For example, if the baby has really immature or poorly functional kidneys, then those kidneys might be dumping sodium a lot. If the baby has a really leaky gut, whether it's neck or whether the baby has gastroschisis and the gut is all in a silo and is losing a lot of sodium chloride through the gut, then obviously they'll need more sodium chloride. If a baby is on diuretics, then obviously they'll need more than that as well. So like we keep saying, at the beginning, when you're trying to kind of figure out exactly how much sodium and chloride and everything a baby needs, then you should probably be checking the electrolytes at least once, if not twice a day in the tiny ones. As the babies kind of get more stable and it's more kind of chronic TPN, then you can probably space out getting the electrolytes once or even twice a week. Right, let's talk about potassium. As you all know, potassium is mostly an intracellular cation, and it has a much lower concentration in the actual blood, somewhere between 3.7 and about 5.7 milliequivalents per liter. Also, the safe index for potassium is a lot narrower. If a potassium is too low, kind of under 2.5, or too high, somewhere above 7.5, then both of those can cause really dangerous arrhythmias. Generally though, if a baby is on kind of stable TPN and not too sick or too much stuff going on, then generally a baby would need between 1 to 2 milliequivalents per kilo per day of potassium. Okay, another couple of important things that you need to consider when you're writing for potassium in the TPN. The first is that generally we do not add potassium on the first day of life or even the first day that we put a baby on TPN. And that's because we're not sure if the baby is going to be urinating adequately or in any sort of renal failure. If the baby doesn't urinate or really the kidneys aren't working yet, then that potassium can build up very quickly and very dangerously. So always give it at least a day, at least 1 day of TPN, and make sure that your creatinine is pretty normal and that the baby is urinating adequately before you start adding the potassium to the TPN. The other thing that I want to mention is that you can often get a falsely elevated potassium on a capstick, so don't necessarily follow that. So remember, like we said, most of the potassium is inside the cell. So when you squeeze the finger trying to get out the capillary blood, then you're probably also bursting some of those red blood cells, and that potassium will leak out and it will be falsely elevated. So remember, always think, is this real or is this just a falsely elevated number? Obviously, the real way to check would be to get an art stick or a free-flowing venous sample. Now let's talk about calcium and phosphorus. So the most important thing that you have to realize is a large part of the baby's growth, especially the bone growth and the mineralization, happens in the 3rd trimester, when huge amounts of calcium and phosphorus are being poured out of the mother and into the baby. So when a baby is born early, obviously a lot of times missing the 3rd trimester, then they're really missing out on a lot of that calcium and phosphorus accretion. Another thing I want to remind you about calcium and phosphorus is that generally we don't give calcium in peripheral TPN because we're worried about an extravasation and it causing skin necrosis, but we can give phosphorus in a peripheral TPN, obviously if there's enough cations to bind with that phosphorus. The calcium level in preterm babies can be a little bit lower than that in term babies. So really the amount of calcium that you're looking at is somewhere between 7.5 and 10.5 milligrams per deciliter. And a normal phosphorus level is also slightly higher in premature babies, somewhere between 4.5 to 7.5 milligrams per deciliter. So obviously it's really important to give good levels of calcium and phosphorus in the TPN. One expert once said that it's almost impossible to replicate exactly how much calcium and phosphorus the mothers are giving their babies in the 3rd trimester. The target intake of calcium is somewhere between 65 to 100 milligrams per kilo per day of elemental calcium and about 50 to 80 milligrams per kilo per day of phosphorus. Generally, when we write for calcium in the TPN, we start at 2 milliequivalents per kilo of calcium, and then we will advance that every day by about 0.5 milliequivalents per kilo per day. So maybe you'll go 2, then 2.5, then 3. In preemie babies, we normally go up to about 3.5 milliequivalents per kilo per day, and in term babies up to about 3 milliequivalents per kilo per day. Because calcium has a 2+ charge, each millimole of calcium has 2 milliequivalents, and the atomic mass of calcium is 40 grams. So 2 milliequivalents of calcium is 1 millimole is 40 milligrams of calcium. So basically advancing up to 3.5 milliequivalents would give about 70 milligrams per kilo per day of calcium. Phosphorus metabolism is tied very closely to calcium metabolism because many of the same hormones, the vitamin D and the PTH and everything, control both calcium and phosphorus. And if we're not giving babies enough phosphorus, then the bone will throw out the calcium phosphate from the bones and everything to try to get up that phosphate level. So sometimes if the phosphorus is low, the way that we will know that is because there is a hypercalcemia, so a high calcium level. So the answer won't necessarily be to give less calcium, but to give these babies more phosphorus. Many different studies have been done kind of trying to figure out exactly the ideal calcium to phosphorus ratio that we should be trying to give in TPN. And it's kind of decided upon the answer of 1.7 to 1, so 1.7 milligrams of calcium to 1 milligram of phosphorus. Annoyingly, that's not normally how we write for the TPN. So really the ratio, if you kind of use slightly different units, is 2 milliequivalents of calcium to 1 millimole of phosphorus. So it really is a 2 to 1 ratio, which at least is easier to remember. You just have to remember it's milliequivalents to millimoles. Using the millimole unit for phosphorus, normally we start at 1 millimole per kilo per day, and then slowly advance that by 0.2 to 0.5 millimoles per kilo per day until we reach 1.5 or 2 millimoles per kilo per day. Sometimes we have to go even higher than this just to kind of correct all the phosphorus and calcium abnormalities in blood, and then we'll go back down to the kind of 1 to 1.5 millimoles per kilo per day that the baby would need. An important thing that you have to remember when you're trying to put a lot of calcium and phosphorus in the TPN is that if you have a high concentration of calcium and phosphorus, then it can end up precipitating. So, or just literally kind of making little stones and clotting off in the catheter or in the blood vessel. Generally, TPN with a lower pH will increase the solubility of calcium and phosphorus. So having more amino acids decreases the pH. The amino acids, also adding cysteine also increases the solubility or decreases the chances of the calcium phosphorus precipitating. So very often we'll add cysteine just for the additional help of helping with the calcium phosphorus solubility. Number 4, the fourth cation is magnesium. Magnesium is a cofactor in over 300 different enzymes, and it's really important in nerve and muscle function as well as in blood glucose metabolism. If your magnesium is low and your calcium and potassium is also low, then you will not be able to just correct the calcium and the potassium without also replenishing the magnesium. So remember as well, the magnesium doesn't normally show up on your basic metabolic panel. So if you do have a low calcium and a low potassium, then you should probably be checking the magnesium and making sure that that doesn't need to be corrected as well. A normal magnesium level is somewhere between 1.3 to 2 milliequivalents per liter. Generally, if a baby has an unstable heart or something, or you really are worried about the muscles and the calcium and the potassium, then especially the cardiologist will want it closer to the 2 level. And after an infant is stable, then basically a baby on TPN will need about 1 milliequivalent per kilo per day of magnesium. Remember, mothers are often put on magnesium right before they deliver for high blood pressure or preeclampsia. Also, they can be put on it to slow down labor as well as for neuroprotection of the infants. So if a mommy has been on magnesium, then that magnesium level is likely to be really, really high in the babies. So if a mommy has been on magnesium, do not add magnesium on the first few days of life in the TPN. Either wait a few days or actually follow the magnesium level in blood. And don't start any magnesium in the TPN until the level is less than 2.5 or 2. Those were all the positive cations. Now, obviously, when we are writing for TPN, we want our fluid to be, neutral. We don't want it to be charged one way or the other. So we also need the anions. Phosphate is one of them. The other 2 major anions are acetate as well as chloride. Acetate gets converted to bicarbonate, so it really is a base for the infant. So really the decision that you're making is how much bicarbonate does the baby want, and if you don't want any, then you'll write for all your anions as chloride. There are really 2 computer systems or different ways that you write for TPN where you decide what the proportion of chloride and acetate you want. The first one is that you actually have to type in or write in the percentage of chloride versus acetate you want. So do you want 100% chloride, do you want 50% chloride and 50% acetate, or whatever? The other one is that you're deciding how much sodium you want, and then you have to check the box whether you want sodium chloride or sodium acetate. So you could want it to be 100% sodium chloride, so you just put 2 milliequivalents of sodium chloride, 0 sodium acetate, etc. Generally, when an infant is first born, they've got loads of reasons to be acidotic. They just transitioned and they obviously came to the NICU for some reason, whether they're a sick term baby or whether they are a preemie baby. And preemie babies have really immature kidneys that waste bicarb really easily. So generally, in the first few days of life, when babies are on TPN, we're giving most of the anions as acetate, which obviously gets converted to bicarb and hopefully balances out some of that acidosis in the baby's blood. But generally, as the babies get older and they get more stable and the kidneys get more mature and they're not dumping out bicarb as much, then a higher percentage of that base will be given as the chloride rather than as the acetate. This is especially true in older babies, whether they're 3-4 weeks old. And that's because a lot of them are still needing some sort of respiratory support. And when babies are on the ventilator or any sort of respiratory support, we accept their CO2s to kind of climb up a bit. It's called permissive hypercapnia, just so that we don't have to beat up their lungs. So we are okay with the CO2s going up to kind of the 50s and 60s. So if the CO2 goes up to the 50s and 60s and you have a respiratory acidosis, then what is the body going to do? It's going to try to retain as much acetate as possible, and you're going to end up with a metabolic alkalosis. So generally in these babies, you don't want to be adding any acetate to the TPN. You want to be adding pure chloride at this point. Let's move on to trace elements. Trace elements are elements that you need in absolutely tiny or trace amounts. If a baby is just going to be on TPN for 2 or 3 days, then the addition of the trace elements doesn't matter as much. But if a baby is going to be on TPN for a really long time, then eventually the baby will suffer deficiencies of these trace elements and can have some serious problems. When you're writing for the TPN, most programs have an automatic amount for the trace elements. So they kind of calculated exactly what a baby would need, and you just have to write for, say, 0.2 mLs per kilo, and it will include all the most important trace elements. Other programs, you actually have to write the amount of the trace element that you want. Standard solutions of trace elements usually include zinc, copper, selenium, manganese, and chromium. And we know a lot about what happens when people lack these elements because of eventual deficiencies that they presented with, or they have some sort of metabolic disorder where they literally can't metabolize one of these trace elements. Let's start with zinc. Zinc is involved in a lot of different functions in the body, especially with growth and with immunity. That's why everybody's always talking about taking as much zinc as possible if you have a cold. The classic board question is that you have a baby who's been on TPN for weeks and they have a really, really bad rash all around their mucosal areas. That is classically a zinc deficiency. So in babies, it can present with a really, really bad excoriating rash. Infants with really bad intestinal issues, so if they've got short bowel syndrome or a lot of diarrhea, or they've got a slick gut, their gut isn't functioning normally, then those babies are at increased risk of zinc deficiencies. And babies need about 400 micrograms per kilo per day of zinc. Obviously, in one of those situations, they may need more than that. Copper is involved in a whole bunch of different enzymes. And just like in Menkes disease, if you have a problem with copper metabolism or a copper deficiency, then you can end up with issues with skin pigmentation, with bleeding and clotting disorders, and ultimately with weakness and then severe neurological deterioration. Babies need about 20 micrograms per kilo per day of copper. What about selenium? Selenium is needed in the function of skeletal as well as cardiac muscles. And some preliminary data has suggested that when selenium is given, infants are less likely to get sepsis and bad lung disease. Generally, babies need between 2 to 3 micrograms per kilo per day of selenium. And as an aside, selenium is excreted renally. So if a baby has renal failure, then you should go down on the amount of selenium that you're giving the baby. Manganese is another element that makes up a whole bunch of enzymes, including arginase and manganese superoxide dismutase. Generally, you need about 1 microgram per kilo per day of manganese. Chromium is also a coenzyme, and a deficiency in chromium is thought to affect glucose metabolism and tolerance. Carnitine is normally added after babies have been on TPN for some time. It is involved in moving the fats into the mitochondria, and it's thought to help with fatty acid oxidation, which becomes more of an issue the longer that the baby is on TPN. Normally we add about 10 to 20 milligrams per kilo of carnitine. As another quick aside, if a baby has cholestasis, so they have liver failure and they are not kind of secreting out their bile, then that baby should be on reduced copper and reduced manganese because they are secreted in the bile and we don't want them to build up in the body. Right, let's talk about the multivitamins now. So the multivitamins are a whole bunch of vitamins that are shown in the following table that are generally not written for individually in the units. Generally, either we end up writing for a dose for the kilo weight. So for example, we would write for 2 milliliters per kilo, and we'll give all the kind of assigned vitamins that the baby needs. Or depending on the weight of the baby, we'll write for a different amount. So for example, if the baby's less than a kilo, we'll write for 1.25 milliliters. If the baby's between 1 to 3 kilos, then we'll write for 3 milliliters or whatever. I'm not going to go through all the individual different vitamins right now. I think that this is something that should be discussed, and obviously it is important, but I just want to mention just like a couple of the high points. The first is vitamin A, which, as you all probably know, is involved in vision as well as good lung growth. And so it really is important that these little babies are getting their vitamin A really early on in their course. Vitamin E is known to be an effective antioxidant. In fact, some of the early studies that were done with giving babies vitamin E showed that it may decrease the incidence of IVH as well as BPD. More recent studies haven't really been able to replicate that though. And then vitamin C, as you all probably know, is involved in wound healing. And so very often if babies do have issues with, for example, they've had surgery or they have issues with their gut or whatever, we may want to add extra vitamin C to make sure that they can heal as well as possible. And the final part, let's talk about all the other things that we may put in the TPN. The first one is iron. So a lot of studies done have shown that adding iron to TPN at the beginning of a baby's life, really for the first few weeks, doesn't really increase their red blood cell production. However, if the baby is on TPN for a long time and we aren't able to add extra iron exogenously, whether it's multivitamins with iron or whether it's ferrous sulfate that you're giving enterally, then at that point there is an advantage with adding iron. So after a few weeks, you should be adding iron to the baby TPN. The second one is cysteine, that we've kind of talked about a little bit. And this is actually an amino acid, and it has an essential role in the growth of many proteins as well as an antioxidant. And it is one of those conditionally essential amino acids, which means that in an adult or an older child that's healthy, they are able to make enough cysteine themselves. But in a preemie baby who by definition is sick, then they probably aren't able to make enough cysteine by themselves. The other thing about cysteine that we've already mentioned is that it lowers the pH of the TPN or makes it more acidic. So this is actually really helpful because when you're giving the calcium and the phosphorus with the cysteine, by definition, by adding the cysteine, the calcium and the phosphorus are less likely to precipitate. However, because it's lowering the pH, if you've got a baby who's already acidotic in the first few days of life, then you don't necessarily want to add more cysteine and make them even acidotic. So very often, we don't really start adding cysteine until the baby's a few days old and gotten over that initial kind of severe acidosis, and that's kind of all going out of their system. And the dose of cysteine that we generally use is somewhere between 20 to 40 milligrams per gram of amino acids that we're giving, because remember, cysteine is an amino acid. And the last thing that I'm going to talk about is heparin. And as you all know, we generally add heparin to the TPN to stop it from clotting. We don't really add it in the peripheral TPN, even though if you've got heparin in it, it's not a contraindication to run it. Amazingly, there isn't really fantastic data that shows that heparin clearly decreases the chance of the lines clotting off. However, we still use it. There is some data that shows that having some heparin makes it less likely that it's going to clot. However, we don't even really know the dose, and many institutions have started lowering the amount of heparin that they use. And so now we generally use somewhere between 0.25 and 0.5 units per milliliter of heparin. Well, that was a lot. That was a lot of dry data. I hope that you all got something out of it. I hope that it kind of does help you as you go on to write TPN. So if you reached this far, then please give us a like and subscribe to the channel if you haven't already. We really appreciate you being here. Thank you.